And then we're going to move on to talk about acute ischemic stroke in children, the incidence, the assessment. We're going to talk about risk factors, investigations, and we're going to focus on the RCPCH guidelines when we talk about the initial management and screening investigations. And we're going to have an exciting conclusion and main take-home message as well, so stick around for that. So to start with this is a real case, someone that I met recently. This is an 11-year-old girl who was previously fit and well. She went to bed as normal, and then woke up around 4 a.m, heard crying. She tried to get out of bed, but she slid off. She couldn't walk. She was unable to move her right arm and leg, and difficult to understand her speech. So the parents called an ambulance about 4:45 a.m. and LAS arrived. The odds were stable, BM was normal. So I would just like to ask the group, what's going through your mind? What would be your kind of differential at this point? What do you think might have happened? Anyone? Yeah, it is a bit of a giveaway that it is a stroke talk. But anything else? Could it be a seizure? Yes, thank you, Rachel. Okay, so we can move on. So I can tell you a little bit more about her history. She is previously fit and well. There was no history of trauma. She went to bed as normal. And there was no preceding illness, no fever, cough, diarrhea, no previous history of headaches, doesn't have migraines, weakness or speech problems. She's got 2 older siblings and family. They're all well. No one is unwell. No significant neonatal history. Immunization is up to date, developmentally appropriate. She attends school at year 7. She really enjoys maths, doesn't really like English. There's been no change in her school performance. So this is very, very acute with this presentation. And she's had chickenpox 2 years at 2 years of age. So she attended ED. I think she arrived about 5:30. By that time, she got to A&E. She wasn't able to weight bear on the right. She was mobilizing significant support. She had right upper limb and lower limb weakness, and she had increased deep tendon reflexes on the right side, and she has noticeable facial droop, and all her obs were normal. She had a slow, soft voice, maybe, but you can still understand her speech. On examination, the ED team, well, the pediatric team actually by that time examined her. She had full range of movement on her eyes, right facial asymmetry when she smiles and puffs up her cheeks. Eye closure is weaker on the right side, weaker forehead movements on the right. Sensation was intact. Coordination, she can only be able to assess on the left side. She couldn't actually move the right side, and couldn't weight bear. She had a flaccid weakness on the right arm. There was no anti-gravity movement at all. She had right leg and some anti-gravity movement on the hip, a bit of kind of knee flexion as well, but nothing really at the ankle and the toe level. She had brisk reflexes on the right upper limb and lower limb actually, and plantar up on the right side. And this is really just kind of a table showing you that she really did have right side of weakness. So at this stage, if you could just write us again on the chat, what would you go on to do next? What would be your next step in certain management with these findings? Oh, perfect. We've got loads of people saying stroke. Could be seizure with Todd. I'm seeing, yeah, CT. Mike saying discharge home. Yes, no chance. So actually, she didn't have a CT, because at the time it was felt that when she went to bed she was completely normal, and now she had this weakness. There was some discussions whether we should CT her or not, or whether she should have an MRI. So actually she ended up having some baseline bloods which are normal, and she had an MRA at her local hospital around 12:30 p.m., so about lunchtime. And around that time, he was reported as having abnormal T2 hyperintense restrictions around the left basal ganglia and corona radiata, which was very, very suggestive, confirms a left MCA infarct. And the MRA was actually unremarkable. And there was nothing else, kind of looking at the vessels and the rest of the brain. And remainder, the intracranial appearance is all unremarkable. And in fact, I've got pictures. These are actual pictures of this child. So this is the MRI scan, and it looks normal. It was reported normal. You have to take my word for it. And this is the T2 diffusion. And the way I remember it is T2 diffusion is when the fluids is bright. This is dark, and this is where the diffusion is around there. So by that time, they discussed her with the local tertiary neurology centre, and she was transferred over for further investigations and management. And I can show you here, this is the MRA, this is how the circle of Willis looks like, on the left and the right. And actually, it was reviewed and reviewed in neuroradiology as well later on. It was thought to all kind of be normal. So there's no convincing clot that could actually be seen at the time. So she was transferred over to the local neurology centre, and she was started just before transfer on aspirin, 5 milligram per kilo, and with some gastric protection. They did initial kind of stroke screening bloods, and we can chat about that in a minute. They started on some IV fluids, but she was still allowed to drink because she was feeling thirsty, and she was able to drink with no coughing. She had close neuro observations, and there was a clear management that if there was any deterioration, when she moved over to the neurology centre to scan her head again. And then she was referred for OT, physio, and speech and language input. And the parents were devastated. This is a previously completely fit and well, typical child, and now she's got this unconfirmed stroke. So they definitely needed a lot of psychology support for her and for the family as well. So the investigations, all the other stroke kind of initial bloods were all normal. The stroke screening bloods are pending, and we can talk about that later, and I'll talk. She had an echo, or another called a bubble echo as well, which was normal, so looking at cardiac problems. She had a 24-hour ECG. She had like a few ectopics, kind of by Germany, a bit at night. We're not sure what significance, but the cardiology will look into it a bit more, but we're not quite sure. So we're still kind of, the jury's out. We're not quite sure why she had her echo, but I really wanted to focus on really her acute management when we go on our talk. But I can tell you about her progress. So I saw her a couple of weeks in, and she was still wheelchair bound, so she needed referral to a rehab centre where she would get intense rehab for a few weeks. She had right-sided facial nerve palsy, she had receptive and expressive aphasia, which the expressive aphasia she was a bit more aware of. There was no overt signs of swallowing dysfunction, but she was monitored closely, but she could actually eat and drink as normal. And speech and language, she had a lot of input as well. In terms of OT, she was fairly independent in daily tasks, less independent in her daily tasks, and that brought on a lot of frustration for her and for her family, and needed a lot of input. And the OT were brilliant with her actually on the ward. She required support to develop independence in dressing, and then there was a plan to reduce her aspirin to 1 milligram per kilo from the current 5 milligram per kilo after 2 weeks, so just before she went to the rehab centre. So I want to move on to talk to you about, if you've got any questions about the case before we move on to talking about acute stroke. I can't see. Oh, I can see here, Rachel, you're in CT FBC usernames. Brilliant. Okay, if you haven't got questions, we'll move on. So I want to talk to you about acute ischemic stroke.
There's one question there, actually. There's one question, but I think we can probably just come to it at the end after you've done your presentation. I think it's best. Yeah.
Sure. Okay. So I have to say, when I started my pediatric training, I was thinking, if somebody said, oh, there's acute stroke in children, I'd be like, what? Stroke in children? Kids can have stroke, really? And I think the thinking now that we do know that children can have stroke, and this is, we need to really be vigilant. There are about estimated 400 children per year would actually go on to have a stroke. And to compare, for example, to brain tumours, there are about 412 children who will be diagnosed with brain tumour. So it's not actually that rare. And we need to start thinking differently, because if you'll be able to see my picture on the left-hand side, you can see there's a little baby who's got this purpuric rash, who's really unwell, meningococcal septicemia, meningitis. Everyone recognizes that they are sick, they are unwell. You get the emergency call, everyone down is in resus, the cannula tray is already prepared, people have assigned roles, you go in, you get treatment, boom, boom, boom. You get in your fluids, your antibiotics, your resuscitation, anaesthesis is called, and there is a clear management plan and escalation plan if they need to go to PICU, because we do know that urgent treatment means it's reversible. And then you look on the picture on the right-hand side, you see a child who's got a bit of facial weakness, can't move their arm, or can't move their leg, especially if they're not mobile. And, you know, I think, oh, they're looking cute, but look really stable, especially if the ABCs are, you know, airway and everything is stable and normal. And we don't have that same sense of urgency. When actually, if we do treat it urgently, then it could potentially be reversible, and we can make a big difference to that child's life going forward. And that is the first step. So there's been lots of drivers for change now to really raise awareness of stroke. There's marked inequality between adults and children presenting acutely with stroke in terms of their management and treatment and how they're actually treated and prioritized. And the stroke guidelines in children that has come on in 2007 have really tried to build that on to increase the momentum and awareness. And there is still a lot of work going on in terms of how we can streamline treatment for stroke in children. So you've got all lovely posters. Now you can find them on the RCPH website. It says, you know, over 400 children would have a stroke, and there is lots of kind of information and charities that would give, you know, information and support. And the first, you know, we use the same assessment tool, which is the FAST tool, which you've seen on TV and on EDs everywhere. Talk, you know, you need to think fast. F is for facial weakness, A is for arm weakness, S is for speech problems, and T is for time, because time is limited. And this is the thought. We need to be time critical, and we need to act quickly if we are to improve outcome. So the incidence of stroke in children, this is based on the Andrew Malik, public neurologist from Bristol, and published around 2013-2014. So the incidence of stroke, ischemic stroke in children, is about 1.6 in 100,000 of children per year. That was based on a population study in the south of England. And you can see that adults have a lot more, about 115 to 150. You are most at risk if you are under 1 year of age. So the risk is 4.4 over 100,000 children per year. And there is a higher incidence in Black and Asian children, which you know, partly because for all the kind of comorbidities and risk factors. So talking on about risk factors are arteriopathies like focal cerebral arteriopathy, abnormal vessels in your brain for some reason, like things like moyamoya, which is called moyamoya based from Japanese, puff of smoke, which is basically a vasculopathy to have a particular kind of the way you see it on the scan, that looks like a puff of smoke. Arterial dissections, AVNs, aneurysms, history of cardiac disease that will increase your, you know, potential for you to have thrombi, and cardiac surgery and interventions, and obviously sickle cell disease. Infections like chickenpox will go on to give you kind of vasculopathies, especially when the highest risk would be up to 1 year. Some people will say up to 2 years after the initial infection, and thrombophilia, or the other causes, you know, risk illicit drug use if you've got a young teenager, something to really kind of be mindful. So kind of in the Andrew Malik paper, they identified 83% of children had risk factors, but really acute ischemic stroke could happen in any child, whether you have risk factors or not. And risk factors cannot always be identified. And this is why we really have to be vigilant and consider it and put it up there in our differentials earlier on. You can have types of kind of ischemic stroke. You can have MCA strokes, which are the most common, the middle cerebral artery, but you can also have anterior cerebral and also posterior circulation strokes as well. And the signs and symptoms and sequelae really depends obviously on the area and how big the ischemia is. Sorry, apologies for the very busy slide. So signs and symptoms of acute stroke in children. We use the FAST screening, which is very, very useful. Facial weakness or and speech disturbance and hemiparesis, which is very common until you can see here from the Andrew Malik paper, that 82% of the children that presented would have these focal sorry. But they can also come with diffuse features, like in children, they can have headache, they can have vomiting, and they can also present with seizures, which 28% of the children actually presented with seizures, mostly focal seizures, but can have generalized seizures as well. And the RCPCH guidelines, they also warn that you can have nausea, vomiting, and fever as presenting symptoms of a stroke. So you just need to really put it in context. So moving on into the acute management of stroke. The RCPCH guidelines are brilliant, but there are about over 300 pages document. And if you're ever feeling bored on one weekend, feel free to go and read them. But I would really recommend that you, if you have a minute, if you have time, to look at the executive summary, which is really clear about the types of stroke, the screening questions, and the acute management, and the post-acute management as well. And they also have this excellent poster that takes you kind of step by step from pre-hospital treatment into kind of the immediate acute treatment, assessment and treatment of children. And we can go through that together. So here is the poster, which you can actually print through the RCPCH website. And it goes through different steps up to step 7. So if we go through step 1, so this is really kind of pre-hospital of thinking, identifying a potential stroke. So acute focal neurological deficit, speech disturbance, change in conscious level, new seizures, ataxia, dizziness, history, also within a history of sickle cell disease. So they need to call on 999, and they need to do ABC assessment, check for hypoglycemia, priority call into ED, and pending arrival for a child with suspected stroke. And I have to say, we don't usually get these calls when you are in ED. When someone says suspected stroke, we get a call for an adult child. Moving on to step 3, this is an ED, and this is really your kind of ABC assessment, and whether if they've got reduced GCS, then you need to intubate them high flow oxygen. If there's compromised circulation, you give them 10 per kilo bolus, and you need to check their glucose as well. And this is really the time it's really important that you write down onset of symptoms to the minute. When did they start having symptoms? So in the day, if they're playing on the playground and then all of a sudden they stopped and they fell and they stopped moving their right arm or leg, started having weakness, we start counting from that moment. If they went to sleep and then they woke up at 5 or 6 in the morning and they can't talk and they can't move, then the last time, your clock started from when they went to bed. If they woke up in the middle of the night and they went to the toilet and you saw them and they went to the toilet, they were all normal and went back to sleep and woke up an hour later, your 0 starts from when you last saw them, where they were, normal and they didn't have the start of the symptoms. And then you're right, 4.5 hours later, and you write down that time, and this is really the window that you have to do your investigations and initiate management if appropriate. So investigations is really baseline, including your FBC and your clotting, your use and ease, your group and safe, your CRP for thinking infection, and obviously our usual monitoring, your blood pressure, your temperature, heart rate, and GCS. And the other slightly different for the kind of initial monitoring and assessment is you do the PED and IHSS score. So this is especially scoring for kind of the level of consciousness, the weakness, the best gaze, and this is really important when we decide later along with the imaging findings whether they should have thrombolysis or not. So the PED-NHSS screening tools is, you can see, is quite long. But there are training tools on the NHSS website. If you Google NHSS, there's a free training tool that you can actually do. And if you are someone who always kind of works in ED or interested in neurology, I would highly recommend it. And you get a certificate for your portfolio if you do the training on how to do it. If you don't have time, if you do on the MedCal calculators, when you Google them, we usually use them in ED to find QTCs, to calculate QTC. You can actually have something similar where you put in, it takes you step by step what you need to write in, and at the end it will calculate your score. And I will leave links at the end of this presentation on how you can access these. Then you will move on to, after your monitoring, you move on to your imaging, and they need to have imaging window within 1 hour. So CT and CT angiogram from a 1 hour ED admission, because you've got that 4.5 hours to actually give thrombolysis. So indication for imaging, this is based on the RCPCH stroke guidelines again, 2017. Just really in general, it's new onset of seizure, onset of severe headache, if you've got reduced GCS, even if it's transient or change in behavior, new onset of ataxia, vertigo, dizziness, sudden onset of neck pain or neck stiffness, and witnessed acute focal neurological deficit, which has since resolved, like for example, a TIA. And then based on your scan, it's either you think they have the symptoms, the scan is clear, and is it, or could it be a stroke mimic? Like for example, I had a seizure and I have kind of post-seizure hemiplegia. So they'll need to have an MRI with a stroke-specific sequences. If we think it is an hemorrhagic stroke, then they will require a discussion with your neurological centre to try and find out whether they'll transfer and management. And then if it shows arterial, if it diagnoses arterial ischemic stroke, then you need to consider suitability for other emergency interventions, which would be thrombectomy or decompressive craniotomy. So treatment for arterial ischemic stroke. So this is part of the poster. If they are not going to receive thrombectomy, then you need to start them on 5 mg per kilo of aspirin. If they meet the criteria, then they need to, for thrombolysis, then you hold off for 24 hours. And this is your step 7. This is a bit of a busy slide, so I wrote it on this one, which would be a bit better. So the RCPCH recommends that thrombolysis could be considered in children presenting with acute ischemic stroke who are 8 years or over, and may be considered for children aged between 2 and 8 years. There's a really good grade 1 adult-based evidence for thrombolysis, as in it does actually give very good outcome. But there is no clear evidence in children, and that's simply because they've got they managed to get very small numbers, even when they tried recently in the States to try and recruit for children. They usually don't meet the criteria, or they're presented outside the window, or they were imaged outside the window, or they so they couldn't actually collect enough numbers to actually prove kind of thrombolysis for children. So the criteria for thrombolysis for acute ischemic stroke, so they need to have the acute focal neurological deficit consistent with an arterial ischemia, and they need to have the PED-NHSS score between 4 and 24. If it's higher than 24, that would be kind of worse outcome, like a higher risk of having complications, so it's unlikely they will receive it. And also it needs to be stable between 4 and 24, not rapidly changing. Treatment needs to be administered within the 4.5 hours of onset of symptoms. That's why it's very important to be very meticulous about when they've actually had the first sign of their symptoms. And neuroimaging, so they need to have normal brain parenchyma and then they have partial or complete occlusion of an intracranial artery corresponding to clinical radiological deficit. So they need to see an artery that is blocked or partially blocked, which corresponds to the neurological deficit, with normal brain parenchyma on the CT, because the signs of ischemia don't happen immediately. So there's no risk that you're actually treating an old stroke rather than a new one. And the last thing, there would be no contraindications, and there's actually a long list of contraindications. I should also note that children, if they have sickle cell disease, this is not suitable for them. They follow a different protocol. If it's sickle cell disease and they have a stroke, you need to contact your local hematology team, because they might need acute exchange transfusion, and then they'll be put on a transfusion protocol regularly to reduce their further risk of stroke. So post thrombolysis, if you haven't started, you wouldn't have started your aspirin, then you need to start at 24 hours. They get repeat imaging at 24 hours for monitoring, and then you need to really monitor them very closely for evolution and progress. In some places they have got an HDU, sometimes you need to move them to PICU to be monitored, and there is a risk of kind of swelling or bleed. So even the children who don't meet the criteria for thrombolysis and they've had a stroke, you really have to observe them very closely in the first 24 to 48 hours, because they do have a risk of having cerebral edema after the stroke, even if they haven't had thrombolysis. So we have to be very vigilant, and they can't go home in the first 24 hours, at least, if not longer. And then you're moving on to screening for risk factors to try and reduce occurrence. So you will do your usual FBC, iron studies, you screen for hemoglobinopathy, so if it hasn't happened yet. You will do plasma homocysteine, galactosidase, fasting blood sugars, you do fasting cholesterols, you check for lupus, anticoagulant, and all the kind of conditions that would increase your your risk of developing a thrombus. Cardiac investigations like ECGs and echoes to try and find structural lesions, left to right shunts. You can see a big thrombus sitting there in the heart, and you might do further imaging as well. And then you do transcranial Dopplers in patients who've got sickle cell disease. And obviously, as we spoke before, your raised risk of recurrence is if you've got an arteriopathy, you've got a pathology that is ongoing, like for example moyamoya or sickle cell disease, you've got a high risk of having another stroke. If you've got congenital heart disease as well, and risk of thrombophilia, like protein C or protein S deficiencies. So I think since the guidelines have come out in 2017, there has been a bit more increase of awareness of stroke and a risk of ischemic stroke in children. But I don't think it's really been the service that we're giving children compared to adults is as streamlined. So adults, they will get a call that it is a stroke. They will go to a hyperacute stroke unit like HASUs. They get their CT within an hour. The CT is clear, it is prioritized, it is reported by the radiologist, and then they receive their treatment. And it happens, it's very much streamlined. This didn't happen overnight. It took them over 10 years to reach that point. And I think we have a long way to go with children if it is something that needs to be introduced. And I know that a lot of, at least around London, a lot of the neurology centres are trying to find protocols and streamlining, see whether it's something that could actually be done within the window and improve the service that we give to young children. So I've got here the an actual audit that was done recently, about a year ago, from the team at the Evelina, from Joshua Collins, Sarawaki et al. And basically, they looked at all the children that had suspected stroke that came through the ED, whether they were seen on it at a DGH and came via ED, whether they presented to the ED at the Evelina St Thomas's. And there were 9 out of the 65 children who were suspected to have stroke. So 14% did actually have a stroke. 78% of them were FAST positive. So it is quite a sensitive screening tool. But actually only 9% had the PED-NHSS calculated and documented. and only 5% had neuroimaging, which is recommended within the hour of presenting. And that was both at the DGH and also at the Tertiary Neurology Centre as well. So we're not doing really great, and there are different barriers to why we're not doing so well. But we also see, opportunity how we can actually improve it. So in conclusion, really, and my take-home message today for you is is to just think on your presentation of such a child, could it be a stroke? So just think of it, have it there as part of your differential. And that is the first step, because some people wouldn't even have thought of it. They wouldn't even have crossed their mind. And once you do, remember, that time is brain. You need to write to the minute when these symptoms have started. When they started suddenly, and then you can access the stroke guidelines and protocol from the RCPCH, which are really, really fairly clearly laid out actually, and how to follow and what to do step by step. You can actually get some training in the PED NIHSS assessment tool. So whether you go via the NIHSS website and do the learning tool, or you can actually just use Google the Med Calculator PED NIHSS, and you can actually do it as well. And thank you. And this is further reading the RCPCH, where you can find the guidance as well. Thanks. So I'm happy to take on questions.
Thanks, Afaf. That was brilliant. And yeah, I mean, just to reiterate that message on the early imaging, it's so important, isn't it? And I think that often what I notice is that people are waiting for an MRI scan, and they're told that it'll happen soon, and then it won't happen for several hours, and the time's been lost to just get the CT angiogram, which should have been done in the first instance. So I think that's just a kind of something that can trip people up sometimes. They should just get the CT scan if they think it's a stroke. And the radiation exposure is actually not that much now with the way that they do CT scans now. So I think the question that came earlier in the talk was quite clearly answered by you in the rest of the presentation. So in the case you presented, the question was, would we do thrombolysis thrombectomy at less than 4 hours if the CT is negative?
So I can answer this one very briefly. I think I know what you mean. So I think when you go back, you need to go the time zero when you're 4.5 hours of doing it is from when the child was last seen being kind of normal, not having the symptoms. So if they went to bed and they woke up and had that weakness, we just count back the hours. And for our case, it was outside the window. The other thing to remember is the window for thrombectomy is up to 12 hours. And given that she was 11 years of age, it's worth contacting your local kind of hospital adult team. I am aware of a couple of cases who did actually have thrombolysis or thrombectomies where they attended at a different centre because they were like kind of early teens, and they prioritised them and treated them and ended up going under the adult team. So the window for thrombectomy is longer. So it's important to get the imaging at the time. I don't think it mattered for our case because later on when she had the MRI, we didn't have a clear thrombus to actually to justify the intervention. And this is the main difference between us and adults. Adults, you go in, you get a scan. If the scan is normal, you go and get a thrombolysis. For children, this is the main difference. You really need to see a thrombus before you give them the treatment. I hope that answers the question.
Exactly, and that's a perfect answer. And yeah, if thrombectomy is increasingly being done, actually, if thrombolysis, we very rarely see it done. When it is done, it's usually because they involve the adult team in A&E, and it's a kind of older teenager, and it's an adult physician who feels confident to manage an older child. But thrombectomy, definitely, and St. George's and Great Ormond Street are the centres to get in touch with about emergency thrombectomy. So another question here from Andrew. We more commonly see presentations of Bell's palsy. What would be your key distinguishing features between diagnosing stroke and Bell's palsy? How far would you investigate to establish this? Good question.
That's a really good question. Yeah, it is a good question. And I think what you need to do, you need to go back to your history. So you need to go back. For Bell's palsy, we'll give you a different history. They might have had an infection, sore throat, an ear infection, something has happened in the past 2 weeks. And how suddenly has it come on? Is there any other kind of red flag features? Definitely a Bell's palsy, as in definitely is it a lower motor neuron rather than an upper motor neuron a lesion, because I've seen a few cases where people confused both and actually did miss a stroke, which they thought it was a Bell's palsy, started them on steroids. And then if you are thinking and you're not quite sure, then they will need, you're not confident on the history, there's nothing there in the history that tells you about ear infection, there's no problem, and they've had this, and there's any other soft problems, slightly increased tone or increased reflexes on one side, or slight weakness, not walking quite right, not talking quite right, then you would go ahead, you do the, you start your clock, I wouldn't see why you wouldn't scan them, and then you see how you would manage it going forward, and just pick up the phone and have a chat with your your tertiary neurology referral centre if you actually really are concerned. It's worth getting multiple opinions, and I do know that neurologists really would hate to miss a stroke, so they'd be really glad that you've actually thought about it.
Yeah. Key thing is distinguishing the upper motor neuron from the lower motor neuron lesion in your examination, isn't it? Looking at the forehead involvement. Yeah. If in doubt, just get the scan. Yeah. Hemat, how to differentiate between stroke and other types of weakness in epileptic patients, such as Todd's paralysis?
Well, if they've got a history of epilepsy, if they're known to be epileptic, I think it's really difficult earlier on, because they really will have that weakness, and you just need to kind of monitor them and see whether they've had it very quickly and stop. Has he had it before? It is tricky, especially if they're presenting for the very first time. I think it's just a matter of monitoring and speaking to the pediatrician or the neurologist who usually looks after them, has he ever had been known to have that, and have TOS paresis following their seizures. I hope that answers it, Hemant.
Any other questions? Looks like you might be free, Faf. I'm just going to share my screen once there.
How can I unshare? Oh, okay. Please stop.
Yep. You can see the grid and spin advert there?
Yes, I can.
Yep. So perhaps you would like to be a spin superstar like a Faf. So if you're thinking about career in pediatric neurology or becoming a general pediatrician with an interest in neurology, then please do attend this online event, and you can talk to grid trainees and people doing spin. And please tune in at 6:30 this evening for a talk on the floppy infant. So thank you very much, Afaf, for your talk.
No problem at all. My pleasure. All right, and I'll be present at the spin information evening, so you'll get a bit more of me at the time to talk to you about this epilepsy. I hope many of you there.
Thanks. Bye-bye.
Right. Thanks. Bye.
Ellie? It was great. Well done. It was brilliant. Very slick. Very slick. You didn't seem nervous at all. Have you? Oh, wow.